So welcome everyone to our weekly orthopedic surgery grand rounds. Today we have a very special visiting professor, and for introduction, I'll turn it over to Dr. Morshed.
All right, welcome everybody to Grand Rounds. It's my distinct pleasure to introduce today's visiting professor, Thomas Higgins, from the University of Utah. Thomas is a graduate of Williams College. He got his medical degree. There you go, right? Medical degree at Brown. He did his residency training at Yale and a trauma fellowship at the Shock Trauma Center in Baltimore. He has spent most of his professional and academic life at the University of Utah, and he's really I've come to know him as a really gifted educator, teacher, and servant to our profession. He's held numerous leadership roles. He's currently the second president-elect for the Orthopaedic Trauma Association. He's an accomplished researcher and has published broadly and edited important references in our field, attesting to the breadth of his knowledge and expertise in the area. In recent years, he's shifted his intellectual curiosity to the topic of pain management, following skeletal injuries, the management, use, and misuse of opiates and NSAIDs, which he'll talk a little bit more about today. On a personal note, I've always admired his dedication and humor and genuine curiosity in the research and professional organizations that I've had a privilege of serving alongside him. We had the pleasure of learning from his insights during last night's Journal Club. He's had dinner with the chiefs. He's going to present to us today in Grand Rounds, and he'll spend an hour with the residents afterwards. And so please help me welcome Dr. Higgins to UCSF.
Thanks, Tom. I appreciate it. It is a real honor to be here. This is a pre-foundational trauma shop in this country, and those of you who are training here are lucky to do so. One of our graduates went on to do a trauma fellowship here, and a lot of the people who work here are folks that have been role models to all of us and have done important things in the field in trauma and in work in the developing world. And like I said, it's a real honor to be here. I normally check with these two before I make travel plans, and I failed to do so today, and I apologize because it's a bit of a hot mess. We circled over the Pacific for a while yesterday, apparently because Air Force One got priority. Anyway, I will remember to check with them next time. My apologies. I grew up in New York, and so I didn't know what square states in the West were called. And so if you're like me, that one's Utah. And just a brief background on our shop. This is where the U of U is located, next to like a giant stretch of 6 inches of salt water. And this is our the piece of coverage that we have. It's the second biggest catchment in the United States, but until Harborview relinquishes Alaska, we are never going to catch them, sadly. But there may be more humans, within 10 blocks of where we're sitting right now than there is inside that circle. I am lucky. We were talking to the residents last time. I'm blessed in my partners. I work with these three guys, and when you're on the road, somebody else is working harder. And these guys, Lucas Marchand, despite the fact that he appears to still be a senior in high school, has taught me more about clinical research than I've taught him. That's for sure. Rothberg's a gifted educator, and Haller's a sort of five-tool player. So I am indebted to them. I am obligated to tell you these are my disclosures. I don't think any of them are relevant to this talk. I was a lifetime runner. This is my usual dose of ibuprofen, but I am not in the pocket of big NSAIDs yet. So I'd love to, I'm an orthopedic trauma surgeon, right? I would so prefer to talk to you about this, right? And how this, What does it take to gut? And I could drone on for far too long about how you turn this into this. But as I learned from Mike Baumgartner, one of my mentors, he wanted to study big trauma topics, but he happened to live in a catchment where there was an oversupply of elderly white women, and he made his name studying geriatric hip fractures. And so it so happens that I was in a place, unfortunately, that was especially afflicted by the opiate crisis. And by dumb luck, I happened to be in one of the first states to be able to track that. So that's how I got involved in opiates. And we were sort of early on that in zeros. And so my background, as Sam alluded to, some of which is in opiates. And that led, interestingly, to NSAIDs. And that's what we're going to talk about today. We'll talk a little bit about NSAIDs, a little bit about opiates. And then I'm going to try something. We all have talks that we give routinely. And I have what the residents now derisively refer to as the opiate nap. You can fill in the blanks. But we're not going to do that. This is a talk I've never given before. I apologize if you feel like subjects in an experiment. But the first half, we're going to talk about the top two topics. And then the second half, we're going to design a clinical trial from the ground up, because I was shocked at it's hard, turns out. So this is, to the best of my knowledge, the first reference where this topic comes up. This is 1976. I was not reading ACTA when I was in the fourth grade, but this is the first reference to it. And it was animal science and very basic. These are the drawings from it. Very basic biomechanics were done on a group of rats as compared to controls with induced femur fractures, and how those bones behaved mechanically, and they behaved poorly. And this was the start, as best I can tell, of this line of research in 1976. Since that time, I think we as orthopedic surgeons are taught, not necessarily as based on the science or the data, but we are taught that NSAIDs interfere with fracture healing. Okay, it's just something we are come to accept. And I also think that sometimes this quote is attributed to Mark Twain, that gossip travels halfway around the world while the truth is still getting its boots on. According to my research source, the internet, people said this before Mark Twain, but he has gotten credit for it. I feel like a little bit about how we regard NSAIDs and fracture healing. There's a couple of clinical papers, though, that really cemented it for orthopods. This is right at the turn of this century. This is from Peter Giannoutis in the UK. And this is, and I would say this if Peter were standing here, this is a poor paper. What it did was it took 32 non-united femurs, and then it matched them with double that sample. It took 67 femurs that had united, and they said they matched them up for everything. Except that, if you look at the diagram in the lower left-hand corner, except that half the non-union smoked and less than a quarter of the united fractures smoked. So I wouldn't call them exactly a matched sample, but this paper has been quoted to me time and time again, because the odds ratio, if you were using NSAIDs, was like unbelievably large, right? If you're using NSAIDs, and they said this caused those non-unions. That was an unconvincing clinical paper. This is actually a paper that really gave us all pause. Cloud Sadji and his co-investigators at the time were actually studying HO prophylaxis, and they had 4 groups of patients, one which just controls, and then various time periods of how long you got treatment. The second group got treatment for a week, 3 weeks, and then 6 weeks. And they all had posterior walls. There's 100 posterior walls randomized. It's a pretty cool paper, right? And the longer you're on NSAIDs, the more likely you were to not unite your posterior wall. Posterior wall is a weird little fracture, and we strip the heck out of it when we fix it, unfortunately. And we excuse ourselves from doing that because, well, we have to, and I still do. But the group that was on the NSAIDs the longest most certainly had a frighteningly high rates of non-union on CT scan. What's cool about this is a clinical trial with 100 patients. They got CT scans on all of them at 6 months. It's hard to do. So that gives you pause. And this was the one other clinical paper that people frequently refer to. This is out of Harvard. It's actually a Medicare claims database paper. And they looked at humoral non-union. And the two things that they found associated with it were the use of NSAIDs and the use of opiates, actually. And this is the first alert in the literature that opiates might have something to do with this. And the problem, the confounder in this is it's retrospective. And if your humerus doesn't heal, you're probably uncomfortable. And if you're uncomfortable, you're probably going to take pain medicine. So chicken and the egg problem. As the opiate crisis, as we became more aware of it and people were looking for alternatives, this is the first trial. And this is not really so much a trial prospectively as a change in treatment paper. But Roy Sanders and his group, they started giving ketorolac, or their anesthesiologist started giving ketorolac in the recovery room. And then they looked at their sample of 30 tibias and 50 femurs, and how did they heal compared to the prior 60 and 100 tibias and femurs? And they healed at no different rate. So their conclusion was that's okay. Obviously, a ton of design flaws to that. This is an interesting way to look at a problem. It's a geographic cohort. So they did is they took a 100-something tibias nailed in Kentucky, and 100-something tibias nailed in Santiago, Chile. The patients in Chile all got NSAIDs routinely after their care, and the patients in Kentucky, because they're in Kentucky, all got opiates. And so this was the result in time to union. Time to union in one group is 181 days. Time to union in the other group is 185 days. And you can see that, the error bars cover, as we say, a wide range of sins, but they said there's no difference in their time to union. We're going to get back to this paper later. So what do you do when you can't answer the question based on the clinical data you have? You start pushing together data. So, or as one of my colleagues in Baltimore cynically says, this data is poor. What we need is more of it. Okay. So this was the first review paper, and it actually said there may be some effect if you push these all together, but it appears to be time related maybe. And the longer you're on it, the greater the effect. This is out of OTAI. This is just recently, and essentially came to the same set of conclusions. It's not the NSAID use, it may be the duration of NSAID use. This paper is out of Australia in the JBTS in 2012, and it was the first one to sort of start to look at this distinction. And this distinction had already been looked at a bunch in animal models, and we're not going to talk much about animal models today because we'd be here all day. Forgive me. But this idea that maybe COX-2 inhibitors were different. And they tried to do a systematic review and then separate out the COX-2 inhibitors specifically. And they came to the conclusion after starting with 25,000 papers, they came down to 316 papers and thought that potentially COX-2 inhibitors had an influence, but that non-selective NSAIDs did not. This is a claims database paper out of Korea that showed essentially confirmed that same set of results. But again, each one of these papers is kind of saying NSAIDs may have an effect, but it may be more related to COX-2 specific inhibitors, and specifically may also be related to duration of treatment. Okay, this is another claims database paper that found that it was associated with COX-2 specific inhibitors and opiate use, but was not associated with NSAIDs. Interestingly, in their conclusions of this paper, they said, well, the opiates thing makes sense because these people are uncomfortable. But the same is not, the same courtesy isn't extended to the NSAIDs. So here's multiple meta-analyses that seem to be showing similar conclusions from pushing all this data together. Interestingly, and there's only so many papers out there, so we have to be examining the same set of papers. Here's a meta-analysis from JAOS that came to the conclusion definitively that NSAIDs do interfere with fracture healing. So it's a little suspicious that we are all looking at the same sets of data and coming to different conclusions. And this is one more claims data paper that actually ended up in JAMA Surgery. There were hundreds of thousands of patients in the claims database and in the, I think, in the 10,000 zone of fractures. And what they found is that non-union was associated with NSAID use and opioid use and benzodiazepine use and the use of antihypertensives and the use of osteoporosis medicine. It almost came to the conclusion that if you were taking any medicine that had a fracture, you had a higher rate of non-union than if you weren't taking any medicine. And if you're in a claims database, you're probably taking some medicine. But it was a second paper now, or third paper now, that brought up this potential that opiates are involved. And so we got onto this question of, do opiates impair fracture healing? And it didn't make sense to us. And we couldn't figure out how we were going to study it, because we already had a database in our state that tracked opioid use, and we had really made hay with that. But what's the problem? We talked about this last night at Journal Club, right? What's the problem with clinical trials on something like union? There's so many variables, so many inputs, and we can't control all those inputs, right? And what did I say happens when we can't control all the inputs? Right, a rat's going to suffer. And so, you're going to go to an animal model, and that's ultimately what we did. I also discovered, as we're looking around, something that the chronic pain people have known about forever, and that was news to me and news to most orthopods I've talked to. You guys know what opiad syndrome is, which is opiate-induced androgen deficiency. About 75% of male chronic opiate users have a serum testosterone level that's equivalent to castration. Okay. If you look at the chronic pain clinics or the maintenance clinics, if they are sort of on the front edge of what they're doing, they're supplementing the testosterone of these people because they're all chronically low. The testosterone in an experimental model drops within 24 hours of administration of opiates. And it's been proven in some studies that in animals that supplemental testosterone would improve bone healing. So now we had a potential mechanism for how opiates were going to interfere with your fracture healing. They were going to make you hypogonadal, and that was going to stop your fracture from healing. So as I said, we didn't know how to control all the variables in the human population. So we started doing rat studies. And so I won't burden you too much with this, but we did a standard osteotomy fracture gap model in 75 rats. And essentially it came down to three groups: the control group, a group that just got opiates, a group that got opiates, and then we gave them testosterone on top of it to try to make up for the suppression. We measured their testosterone to make sure they were suppressed, and they were suppressed. And we went back to, right, I said 1976, study in Oslo, they're studying just the mechanical strength, right? We started looking at the strength of, and the black bar of the morphine. As the callus, as a callus aged, it didn't mature. It got bigger, but actually didn't get stronger. It was significantly weaker than the control rats. And it puffed up almost like it was trying, but just wasn't. It was making more callus. It was poorer quality. This is histology, I'm told. So, and the same thing for the strength testing. And then our third group now is a group in which we gave supplemental testosterone. And the problem with the supplemental testosterone, the exogenous testosterone, is it didn't rescue. The idea is we're going to rescue them from their hypogonadism, and they're going to heal the fractures, and the callus is going to become strong. Didn't have that effect. So that was a little disappointing. But it did give us a little bit of inclination that, yeah, opiates are potentially part of this problem. So now I'm going to circle back towards the NSAID thing for a minute or two, for a couple of slides, and then we're going to chat more about how do we address these questions. This paper is out of the general surgery literature. This is out of the University of Tennessee. And what they did was they looked back at the previous 1,900 patients that had a fracture stabilized and what their rate of NSAID use was and what their rate of non-union was. And Sam has spent some time, I believe, on the program committee at the OTA, myself as well, and nothing, I think, sours a reviewer on an abstract greater than, like, just state what you found. Don't overstate the importance of that. This group of investigators said that we held a divergent group from the orthopedic community, and we were able to perform a prospective trial with sufficient power. And it remains unlikely that you could, actually, it's unlikely that you could do a paper, because after what we found here, it would almost be unethical to do so. We have pretty much put this question to bed. And we've altered our own practices after these. This retrospective study may in fact limit the ability now to perform a prospective trial because the intervention of NSAID dosing is deemed harmful and should be avoided. That's a little bit of a reach on a retrospective look at 1,900 patients based on a database. Interestingly, Anna Miller and colleagues, this is in JBJS Reviews, which is a neat publication, I think, because it tries to put all we know into one spot for us, digest it for us. They looked at what was the quality of the research, and there were two interesting conclusions out of this. There's a methodology for judging effectively the quality of your references, and they said that the quality of the references was significantly lower in those papers that showed that NSAIDs were harmful, and it was about the same in those that showed that NSAIDs were the same. And the conclusion that I would agree more with Anna's conclusion than with the prior paper's conclusion is that unanimously all reviews admitted to the need for prospectively randomized controlled trials to help clarify the effects of NSAIDs on bone healing, right? Rather than this is settled science, we actually don't know much. This is a bit of a meta-analysis we did and a bit of a policy paper with EAST. EAST is the Eastern Association for the Study of Trauma. It's a largely general surgery, trauma surgery group, but they teamed up with the Orthopaedic Trauma Association to look at this. It did something called a PICO analysis, which looks at population, intervention, comparisons, and outcomes to try to examine each bit of the literature in terms of what's out there and how is it relevant to the question you're trying to ask. And it was the first paper, I think, and I'm biased because I was involved in it, it's the first paper that addressed, one, research quality with regards to NSAIDs and what's the conclusion of the NSAIDs. And the conclusion was there might be a little bit of an effect. But the balance was, but the downside of the opiates may be so great that even if you were to cause a couple of sterile non-unions, like for my money, a sterile non-union is a problem I can fix, but opiate addiction and the things that go along with that are much harder. 40% of those in opiate rehab in one paper said that their first exposure to an opiate was in the medical setting. Okay. In a paper we did when we started all this back in 2009, we found that 12% of the trauma population have been prescribed an opiate in the prior 3 months prior to their injury, but that on the back end, 20% after 3 months were still using opiates. So we're introducing people to the medicine. All right, so if we could introduce less people to the medicine by giving them NSAIDs, that's where the balance is struck. So despite what I would say is, after reviewing all that evidence, pretty middling evidence that NSAIDs do or do not have an effect, this paper said that 88% of orthopedic trauma surgeons surveyed for this believe that NSAIDs are an impediment to union. So either we're misinterpreting the literature, or I'm misinterpreting the literature. But the bottom line is we don't have an answer to the question yet. So it's an orthopedic talk, so we're required to have a picture of someone doing sports. This fellow is Mike Anderson. He went to the University of Utah, which is why we're partial to him. He was the NFL Rookie of the Year when he finally got to the NFL at the age of 29. Mike spent 4 years in the United States Marine Corps. Then he went back to college. And yeah, as I said, arrived in the NFL at the age of most of the guys in the NFL are retiring. And why is that relevant? Because I have done a bunch of this research on the bench, et cetera, right? But at the tender age of someplace in my 50s, got my first federally funded grant for a big clinical trial. That's also not when you start doing these sorts of things. So my point is, I don't want to misrepresent myself as an expert, right? It's almost embarrassing that I'm doing this in front of Sam. He should be up here giving this talk. But I find that by coming late to the game, I learned a bunch of stuff that it had never really dawned on me. And many of you are never going to do clinical trials or participate in clinical trials, and that's fine. But God willing, you're going to read clinical trials the rest of your life, and it helps to think about what went into them, right? We spent the better part of an hour hammering 4 papers yesterday that get into pretty snooty journals, right? And if you can hammer those, right? So much time and effort went in on the front end to the considerations in that trial. So this is the grant that I am referencing, and I'm required to reveal. Was funded by the DoD. This is through the Metric Center. The Metric Center was discussed some last night. And we felt that given that 88% of orthopedic surgeons, orthopedic trauma surgeons nonetheless, believe that NSAIDs interfere with fracture healing and the opiates are a crisis, and that NSAIDs are, despite what your patients, have set in their heads, NSAIDs are in fact pain medicine, effective pain medicine, that if we could determine if NSAIDs actually interfere with fracture healing, then maybe we could have less people on opiates and maybe put this question to bed. We also discussed last night, remember, you can publish a good trial on something, and orthopedic surgeons will sometimes have 2 reasons why they can't do that. Is 1, their patients are different, which is probably not true. The patients are the same as everybody else's patients. And 2, the way I do it is different. I got the special, I got left over right over left. It's the same. It's an operation. So you want to make it universal. The funny thing about winning a grant finally, and generally, you apply, you fail, you apply, you fail, you keep tuning it up. There's this interesting movie. It's quite dated now, from the 1970s. Robert Redford was running for U.S. Senate for the state of California. He was an underdog, wasn't supposed to win, and he spends the entire movie campaigning. And the final scene of the movie is they let Robert Redford know that he's going to be the next senator from the state of California. And he goes, "What do we do now?" I mean, that's what happens when you win a grant. You're like, yeah, now we have to do this. All right. So now I'm hoping that we do a little audience participation, hopefully largely with the trainees. And we're going to talk about, so I have hopefully, please. No, this is great.
I wrote the Edward of the Orthopedic Oncology Theater.
Hi. You built up. Now it's going to go in the tank.
Even a question in another one, or in countries where they aren't using opioids for pain medication, and they're using Tylenol and NSAIDs, are those traumatologists also not using NSAIDs? Are they over here looking at us saying, "Why are you even studying this year after year after year? We don't give opioids. We give NSAIDs. Our patients heal."
So a couple of things. So the question. Not as firm as it is culture. It's also on its bubble. interesting to go over. If a real opioid is not that, but they have like similar number, either whatever sort of legislation. No, and it's a great question to ask. I'm not sure that I know the answer to how firmly this is held overseas. Right. There's a ton of people in this room who've done a ton of important work in the developing world, and it's given out because it's what you have. Right. Good question. We're in the freeform jazz exploration portion of this, so yeah, go ahead.
What's the role of activity level? Analysis in the labs, they're kind of hypertrophic, maybe went on to heal. There's probably a little bit of micromotion with any of fixation. How do you control for the impact of activity levels? Maybe pain relief leads to more activity, which delays union because they're moving and walking more. You control for the activity of the mice because of the analgesia effect.
No, you don't control. I mean, as much as you can control the mice as they're in a cage, right, or rats in our studies. But no, they're all given activity ad lib.
So, do any of the clinical studies, the well-done ones that you think control for activity?
No, and we're gonna do. That's great because we're gonna very much get into what about that. Okay. Good, thank you. All right, so I'm gonna skip over the question. The question is, let's say we're all now gonna design a trial, and the trial is, do NSAIDs interfere with fracture healing? So let's say that's our question. Okay, so we're going to skip the question slide. Do NSAIDs interfere with fracture healing? So we're talking about our model. We're going to do this clinically, or we're going to do it in the bench. We said we got plenty of bench research out there, right? So I'd say that we're going to attempt to do this clinically. All right. What bone do you want to study? You want to study all of them? The scaphoid. Sorry, I just nodded off. What did you say? The scaphoid is definitely a bone that doesn't heal. But I was hoping for one that I know how to operate on. Okay, what do you want to study? All bones? That's an option. All these big meta trials, they take all bones.
Yeah.
You want to upper extremity? Which one's more likely to heal? Your upper extremity or your lower extremity? More likely to heal. I think more likely to heal is the upper extremity. I think that would bear out. I heard tibia. I heard femur. What kind of bone are we looking for? Oh, okay, long bone. But like, what do you want? Long bone, right? So you want a bunch of them. What else do you want? You want ones that are reticent to heal. Okay, what do we say about broomsticks and femurs an hour ago? Right, yeah, I mean, yeah, it's just, the femur just loves healing. So, and the tibia honestly loves healing too, but not quite as much as the femur. Okay? Do you want a bone where there's like 7 different operations that you're going to do on it? No, you'd love some uniformity of the operation, because that way you can stop people from saying, oh, but I do it differently. I do it this other way. There's only a limited number of ways in which you can get a rod inside the tibia. And we believe me, we argue over those. I've got opinions, but it's still a rod inside the tibia, regardless of how it got there and how much cartilage you damaged on the way. Sorry, I revealed my biases. Okay. Who can explain to me, there's these two sort of broad thoughts of how you design an experiment, explanatory versus pragmatic. Who's what? We talked a little bit about pragmatic last night, and it starts to talk towards your question, right? What's pragmatic mean? The real world, okay. Sorry, you were totally barking. I'm sorry. What was the last thing you said about explanatory? I couldn't quite hear it. The way I think of it is explanatory, you're going to control for every variable, everything. So you're going to knock it down to one, right? Variable means something that varies. Going to knock it down to one variable. Pragmatic is, we realize there's a little bit of difference in how much rigidity is in your fixation, or one of the pragmatic trials on oral versus IV antibiotics for fracture-related infection was so pragmatic that their endpoint was not whether or not you took the oral or the IV antibiotics. It's whether or not you were given a prescription for it. That's the endpoint. And their argument is, that's all we can control. I mean, it's a little liberating, right? You don't even need to study compliance. Yeah, I gave them the script. But that is what you do in the clinic, right? You give them the script. And now, if they are totally not compliant with what you ask them to do, then that diminishes it's going to increase the number you need to get power. Okay. So which one of these do we think we're more likely to study? We're going to try and figure out, wait, hold on. We decided we're going to study tibias. We decided they're all going to be nailed. Okay. Is it okay if it extends into the joint? Why not? Okay, so now we're gonna get this is exactly the stuff that shocked me. I was like, oh, wait a minute, we actually need to spell this out. Yeah, we actually need to spell this out. It's a bear, right? Because here's the trick is we're gonna dispense this out to 16 centers. And unless I'm willing to have them call me every day and go, it's just a little crack. It's depressed, but it's not that bad. Okay, so you guys are like, no, I can't have that. What are you doing when you say I can't have that?
Less generalized.
You less generalized. Well, what else? Yeah, you're getting less patients in your study right now. So wait, are you arguing for or against them? Okay. But so 38% of spiral distal tibias have a posterior mal. You're throwing them all out. 30 of your patients right now. You're way less nervous about enrollment than I am. Come on. All right. We're going to circle back. So it's starting to sound fairly pragmatic at this juncture. Okay, so we're going to nail tibias. It's a pragmatic trial. Now, are we here? What are we here to establish? Superiority or non-inferiority? Am I trying to prove that NSAIDs are good for your fracture? Okay. What's the problem with non-inferiority? We talked about it last night. It's going to up your N, right? It's going to be, now, how do you blind? Now you're doing a drug trial. This is unpleasant, right? How are you doing a drug trial? How do you blind a drug trial? Okay, so placebos. Okay. Why do we blind a trial?
Yeah.
Okay. So that's the patient side. Okay. But you wanted to double blind it. Why do you blind the doctors? Wait, you disagreed with someone over whether or not a fracture is healed? I bet you have. So, what's the downside of blinding? Yeah, it's driving up the price of your trial, right? You've done some clinical research. Yeah, you've dealt with an investigational pharmacy. Yeah, well, I mean, those are strong words, but sure. Yeah. So once you start introducing a placebo, if you're going to blind a trial, you're going to introduce a placebo. You start introducing a placebo. What is another way? And so you can introduce a placebo, or you could introduce another medicine that is effectively a placebo. What if we gave half the patients ibuprofen and we gave half the patients acetaminophen? Is that okay? Why not? Because your presumption is that acetaminophen has no effect. Okay, that's a good argument against it. Another argument against it is, all right, so it's a pragmatic trial. What are you going to tell the patients that are in the control group that they're not allowed to take any NSAIDs now? Okay, what are they going to get to take? Opiates, just opiates, and Tylenol, right? So now you're going to give them Tylenol and Tylenol, right? So there may be an argument for having it be ibuprofen versus placebo, actual placebo, or ibuprofen versus nothing. Right? And so, right, that's not an option, right? Right. So part of your pragmatic concessions may be, you can give them whatever you want, but we're only going to control one variable. We're going to control ibuprofen or not. Okay, so I keep calling it ibuprofen. What if I want to give them celecoxib? Right? Yeah, exactly. Where are you out, right? You start, because some center is going to call you like, yeah, well, we use naproxen. What's that going to do to your trial? Is it going to throw it out? You're going to throw it out based on this journal club last night, like, oh, some of them are on naproxen. I think that's a fair argument. It's a fair argument. Okay. Okay. Endpoint. This is for my money. And if you're doing your R2 project, or if you're trying to draw a big trial, endpoint for my money is the killer of more well-intentioned research projects than anything else. It's either choosing the wrong one or not clearly enough defining the one that you have chosen. Okay, so let's talk about endpoint. What did we say our question was? Do NSAIDs interfere with fracture healing, right? Okay, so what's our endpoint? It's our primary outcome. Good. Yes. Did the fracture heal? So you want to go, so you're voting for healed versus not healed. Okay, anybody for time to healing? Because didn't I tell you that NSAIDs may pump the brakes on healing, but you might heal anyway? Maybe we're making them all heal slower. Don't you want to know the time to healing? No, you don't. Yes, you do. You're happy. You don't care how long it takes. It's not my leg. Yeah. Okay. Do you want time to healing? Secondary, but nobody's for time to healing for a primary outcome. You want time to healing. Okay, because it's a continuous variable. Great. Okay. Good. We're going to get to that, but first I want to start with time to healing. You said it's a continuous variable. Now you're wondering how I'm going to challenge that. Yeah. Okay. All right. So you guys we referenced earlier that it's good to go to clinic, right? When do the patients go to clinic after their operation? I am now, right? We could all recite it from heart because these are exactly when they must be seen. 2. What else? Oh, okay. Well, California, it's 12. Okay. And then after, so this is 3 months, right? Then when do you get seen? 6 months and 1 year, right? Okay. Remember this paper? And it was time to healing. It was Kentucky versus Chile. It's amazing. This is 180 days. This is 185 days. What's 180 days? It's 6 months. That's interesting. Is it really a continuous variable? No, because it's continuous if you saw them every day and x-rayed them, and that will make them not heal. But if you saw them every day and x-rayed them, then it's a continuous variable. But they all came, it so happens that even 2 continents, everybody healed at 6 months. It's because that's the day you took the x-ray. So it's not really, and I would argue, and there's tons of orthopedic studies that use time to healing as an endpoint. It's a garbage endpoint because it just matters. And here's the other thing. Here, we'll talk about it right now. That heal? Show our hands. Healed? Nobody. He's walking on it. I don't think it's sealed. What's that? Hurts a little. Okay. All right. So I wouldn't say we have consensus on that. Okay. How about, is this sealed? So you want every little bit of the fracture to be gone, gone, gone. Okay. What if I told you she's 6 weeks out? Now, do you think she's healed? Now you definitely don't think she's healed, right? Because she's 6 weeks out and you can still see some lines. So I guess what I'm trying to demonstrate in the most painful manner possible is that healing is not a clean endpoint. And then many of you wanted to know when. So this has been studied because everything's been studied. Yeah, and no, we can't define healing. Let's take a clinical case. This person broke their tibia, put an intramedullary device in it. This is that person at 6 weeks healed. 6 weeks. No, good. 12 weeks. 6 months. Yeah. 12 months. Yeah, done, right? Yeah, definitely done now. Definitely done. Okay. But we don't know. And also, we argued these images were 3 months apart, and we sort of waffled on whether or not they were healed. So if I x-rayed the patient every day, you'd still be waffling, right? So that's why time to healing isn't necessarily good. It's also why healed is not necessarily good, because we can't agree on it. All right, so what else are you going to do? You said our endpoint is healing. Reoperation. You like reoperation. I'm with you. Why? Okay, so let me go back 2 slides. Here we are. We got some waffling on this. We definitely have some waffling on. No, we'll go here. If I take these 2 screws out, is that a reoperation? It is a reoperation. Sorry. It is a reoperation. Is it a reoperation to make her heal? I totally agree with you. Reoperation is a good one, but there's further subtlety to it. We have to define it as reoperation to promote healing. Now you're digging into like the op report. Have you read some of these? Honestly. Like, you were talking about this last night. Some of the op reports are like, patient went to the operating room for the operation they needed, and it went well. They recovered uneventfully. That's not helpful. So now you have to be able to adjudicate what is an operation to promote healing. But yes, it's the clinically relevant we talked about last night, right? Would you rather have a bleed to your head, or would you rather have a DVT, right? And what are the relative risks of each one of those? What matters to the patient? Well, probably what matters to the patient is if they're going to get another operation to get healed, right? Yeah. So that's your healing endpoint. That's the other that we went with was reoperation to promote healing. Am we like 7 hours over time right now? Wait. A few minutes. That's okay. I don't have any more slides. So okay. Yeah. How long do you want to follow? This is something you only know if you go to clinic. How long does it take the tibia to heal? 181 days. Right? But you got the minimum you got to follow them is 6 months. And some of those people that you thought were healed at 6 months are going to come back at 9 months and they're hurting and they need an operation. So we came to the conclusion you got to follow them for a year. 2 years would be great, but the longer you want to follow them, the lower your follow-up rate's going to become. All right, we'll cover this slide. There's more slides. We're just going to cover this. Where does the study start? Time 0. Does it start when you break your leg? No, because you're not in the study. You're not signed up. As soon as the operation ends, well, you come to the hospital, you get whisked upstairs, you get an operation. I never had a chance to sign you up. What's that? First follow-up? But now you've got 2 weeks where you haven't given them any NSAIDs if they're in the treatment group.
Surgery.
Consent, so it's at the time of consent? Okay. Could you do a composite time 0? Remember we talked last night about a composite endpoint, death or inability to walk 10 feet? What if you said time of operation or time of consent for the surgery, but you got a consent for the surgery within 48 hours of your operation ending? That gives your coordinators a little bit more time to sign people up. 48 hours. Why 48 hours? Because that's how long a weekend is. But these are practical considerations. Okay. And then are we going to track them inpatient or outpatient? Both. Okay. So what counts as compliance? If they get it inpatient, or what if they got it inpatient but they didn't get it outpatient? Is that compliant? They got to get both? Or are you going to have 2 compliance numbers? Right. So I guess what I'm trying to demonstrate is that there is a lot of, and I'll show one other slide that I think is more meaningful if you're thinking about this sort of thing. And that's this. These are the audiences you have to satisfy. You want patients to want to enroll in your trial. Okay, you can't talk them into it. You're not going to try and talk them into it. You make it crystal clear. Whether you enroll in the trial or don't enroll in the trial, you're going to get the same excellent care. But you want to make it so that they're willing to do it. You also want to make it surgeons, and each surgeon does it their specific way, and because that's the right way, and there's no other way to do it. But you want to make it so that surgeons are willing to participate in your trial. Your audience is also the research staff. It needs to be practical. They can actually enroll these people. And if you follow 10,000 variables post-op, you're not going to get all that data collected. You got to get skinny enough that it's practically executable. And then last, is this the kind of study design that JAMA is going to be interested in? I don't know. I've never published a paper in JAMA, but fortunately, there's smart people who advise us on this. So, this also goes into your design. So, from a summary standpoint, I think the NSAID question, I mean, for my money, I am convinced going into a trial, right? I am convinced that I believe I know what the answer is, but we do a trial and if I learn that NSAIDs interfere with fracture healing, then good. Now we've all learned something. The data, I don't think at this time supports a prohibition of NSAIDs. And if you think about balance, NSAIDs are valuable pain control and lessen the use of opiates. Both of those things are demonstrated. Yeah, so you have to think about the cost-benefit analysis of one versus the other. And clinical trial design, interestingly, is about simplicity, but achieving that simplicity is remarkably complicated in the thought process that takes you to get there. Questions?
Dr. Higgins, that was great and very fun exercise too. And thank you so much for making the trip. I think Dr. Stroud had her hand up. We'll take maybe one question. I think we're right.
Yeah, sorry, I'm keeping us over.
Hi, Dr. Higgins. So this is about your primary literature review. I looked at the data in peds and adults a while back. My current belief is that our data suggests that early, not high dose, not continuous doses, like in the first 2 weeks perioperatively, is not harmful or not demonstrably harmful. Would you agree?
That's the most bomb-proof thing you can take away from the literature, is that early use is probably harmless. And we didn't get into, we're continuing these people for out to 6 weeks because we really want to know if it matters.
That makes sense.
And what's funny is the mechanism we all thought about with this was inflammation. That, like, you were made to memorize the 4 stages of fracture healing in med school. That early inflammation and bleeding is critical. And the thought was NSAIDs interfere with that. But it appears that the early use of the NSAIDs is definitely not a problem. So we probably have the mechanism wrong. Yes, sir.
One skateboard is spy code. A lot of work right now. Yeah. Degree and how to love the say that hospitals are public spine shit. Right. Do we have anything extrapolated?
So that's great. And so much of the literature has been done. So many rats have had their spines fused or not fused over the years in pursuing this, right? And for my money, I don't think that fusion and fracture healing are the same thing. I fixed a clavicle on one of our neurosurgeons, and every time he came to clinic, he goes, "Is it fused?" I was like, "It's called healed." I think fusion is a different mechanism than fracture. They're in the same family, but I don't know that they are comparable processes. And so I can't answer your question. And but I do know, I will say, I was discussing this issue at the AOA, which prides himself in being super sort of academic about things. Like, the spine surgeons are the most vociferously like, no. Right? And yeah, so I think that's out. And I think that's going to be the last group. If, let's say, we find there's no difference, that's going to be the last group to convert on this issue. Well, you know what? And I got a lot of no, and my patients are different. Yeah. So I'm sorry I can't answer your question.
All right. Well, thank you so much. And then just as a thank you also, we have this for
Well, thank you very much.
your visit. Thanks.